Hello class, welcome to the recorded lecture on Chapter 25, Bleeding. After students complete this chapter and the related coursework, they will understand the structure and function of the circulatory system, the significance and characteristics of bleeding, the importance of personal protective equipment when treating a bleeding patient, the characteristics of external and internal bleeding, how to conduct a patient assessment, and the methodologies for controlling bleeding. Introduction. After managing the airway, recognizing bleeding and understanding how it affects the bodies are two of the most important skills you will learn as an EMT. Bleeding can be external and obvious or internal and hidden. Either type of bleeding is potentially dangerous and can cause weakness, shock, and death. Uncontrolled bleeding is the most common cause of shock following a traumatic injury. Anatomy and physiology of the cardiovascular system. The cardiovascular system circulates blood to all of the body's cells and tissues, delivers oxygen and nutrients, and carries away metabolic waste products, responsible for supplying and maintaining adequate blood flow. Components. The pump, or heart, the container, which are the blood vessels, and the fluid, which is the blood and bodily fluids. Heart needs a rich and well-distributed blood supply, works as two paired pumps, the upper chamber, atrium, and the lower chamber, ventricle. Blood leaves each chamber through a one-way valve, which keeps the blood moving in the proper direction. This figure shows the right and left sides of the heart. Blood vessels and blood. Types of blood vessels. Arteries carry blood away from the heart, become smaller the further they are from the heart. As blood flows out of the heart, it passes into the aorta, the longest artery in the body. Arterioles are smaller vessels that connect to arteries and capillaries. Capillaries pass among all the cells of the body and link arterioles and venules. Venules are very small, thin-walled vessels that empty into the veins. Veins carry blood from the tissues to the heart. Oxygen and nutrients easily pass from the capillaries into the cells, and waste and carbon dioxide diffuse from the cells into the capillaries. This transportation system allows the body to rid itself of waste products. Blood contains red blood cells responsible for the transportation of oxygen to the cells and for transporting carbon dioxide away from the cells to the lungs. White blood cells responsible for fighting infection. Platelets responsible for forming blood clots. Plasma, the fluid portion of the blood. Blood clot formation depends on several factors. Blood stasis, changes in the blood vessel walls such as a wound, blood's ability to clot affected by disease or medication. When tissues are injured, platelets begin to collect at the site of injury. Red blood cells become sticky and clump together. Protein in plasma reinforces the developing clot. Autonomic nervous system monitors the body's needs from moment to moment, adjusts blood flow by constricting or dilating blood vessels, automatically redirects blood away from other organs to the heart, brain, lungs, kidneys in an emergency, adapts to changing conditions in the body to maintain hemostasis and perfusion. If the system fails to provide significant circulation for every body part to perform its function, shock results. Pathophysiology and Perfusion. Perfusion is the circulation of blood within an organ or tissue in adequate amounts to meet the cell's current needs for oxygen, nutrients, and waste removal. Speed of blood flow must be fast enough to maintain adequate circulation throughout the body and to avoid clotting. Must be slow enough to allow cells time to exchange oxygen and nutrients for carbon dioxide and other waste products. Some tissues need a constant supply of blood, while others can survive with very little. All organs and organ systems of the human body depend on adequate perfusion to function properly. Some organs cannot tolerate interruption of blood supply for even a few minutes without sustaining damage. Death of an organ system can quickly lead to death of a patient. Emergency medical care is designed to support adequate perfusion until the patient arrives at the hospital. The heart requires a constant supply of blood. The brain and spinal cord may last 4 to 6 minutes without perfusion. The lungs can survive only 15 to 20 minutes without perfusion. Kidneys may survive 45 minutes. Skeletal muscles may last 2 to 3 hours. The gastrointestinal tract can tolerate slightly longer periods. Times are based on a normal body temperature of 98.6 degrees Fahrenheit or 37 degrees Celsius. Colder temperatures will lengthen survival times. External bleeding. Hemorrhage means bleeding. External bleeding is visible hemorrhage. Examples: nosebleed and bleeding from open wounds. The significance of external bleeding. With serious external bleeding, it may be difficult to tell the amount of blood loss. Blood will look different on different surfaces, absorbed in clothing versus diluted in water. It is important to estimate the amount of external blood loss. Treatment should be based on the patient's presentation and MOI. The body will not tolerate an acute blood loss greater than 20% of blood volume, about 2 pints. The typical adult male has approximately 70 milliliters of blood per kilogram of body weight. The typical adult female has approximately 65 milliliters of blood per kilogram of body weight. Adverse changes in vital signs may occur with significant blood loss. Increase in heart rate, increase in respiratory rate, decrease in blood pressure. Because infants and children have less blood volume to begin with, the same effect is seen with smaller amounts of blood loss. How well people compensate for blood loss is related to how rapidly they bleed. An adult can comfortably donate 1 unit, 500 milliliters of blood over a period of 15 to 20 minutes. If a similar blood loss occurs in much shorter period of time, the person may rapidly develop symptoms of hemovolemic shock. The age and pre-existing health of the patient should be considered. Blood loss is an extremely serious problem that demands immediate attention even before the airway and breathing are addressed. Characteristics of external bleeding. Injuries and some illnesses can disrupt blood vessels and cause bleeding. You should consider bleeding to be serious if the following conditions are present: poor general appearance and no response to external stimuli, signs and symptoms of shock, hypoperfusion, significant blood loss, rapid blood loss, uncontrolled bleeding, significant MOI. Arterial bleeding. Pressure causes blood to spurt and makes bleeding difficult to control. Typically brighter red, rich in oxygen, and spurts in time with the pulse. Decreases as the amount of blood circulating in the body drops and blood pressure drops. Venous bleeding. Dark red, low in oxygen. Flows slowly or rapidly depending on the size of vein. Does not spurt and is easier to manage. Can be profuse and life-threatening. More likely to clot spontaneously than arterial blood. Capillary bleeding. Bleeding from damaged capillary vessels. Dark red, oozes from a wound steadily but slowly. More likely to clot spontaneously than arterial blood. Clotting process. Bleeding tends to stop rather quickly within 10 minutes in response to internal mechanisms and exposure to air. When the skin is broken, blood flows rapidly from the open vessel. The cut ends of the vessel begin to narrow. vasoconstriction, reducing the amount of bleeding. Next, a clot forms, plugging the hole and sealing the injured portions of the blood vessel. Coagulation. Bleeding will never stop if the clot does not form, unless the injured vessel is completely cut off from the main blood supply by direct pressure or a tourniquet. Despite the efficiency of the circulatory system, it may fail in certain situations. Movement, disease, medications, removal of bandages, external environment, body temperature, and severe injury. Hemophilia. The patient lacks one or more of the blood clotting factors, several forms. Most are hereditary, some are severe. Bleeding may occur spontaneously. All injuries, no matter how trivial, are potentially serious. Patients should be transported immediately. Internal bleeding. Internal bleeding is any bleeding in a cavity or space inside the body. It can be very serious because it is not easy to detect immediately. Injury or damage to internal organs commonly results in extensive internal bleeding. Can cause hypovolemic shock. Possible conditions causing internal bleeding include stomach ulcer, lacerated liver, ruptured spleen, broken bones, especially ribs or femurs, pelvic fractures. Often the only signs of internal bleeding are contusion or echomeresis. Mechanism of injury for internal bleeding. A high energy MOI should increase your index of suspicion for the possibility of serious unseen injuries. Internal bleeding is possible whenever the MOI suggests that severe forces affected the body, blunt trauma or penetrating trauma. Use the mnemonic DCAP BTLS to assess for signs of injury. Deformities, contusions, abrasions, punctures or penetrations, burns, tenderness, lacerations, swelling, and any other signs of injury. Nature of illness for internal bleeding. Internal bleeding is not always caused by trauma. Possible non-traumatic causes include bleeding ulcers, bleeding from the colon, ruptured ectopic pregnancy, and aneurysms. These signs are frequent, but not always present. Abdominal tenderness, guarding, rigidity, pain, distension. In older patients, signs include dizziness, fainting, weakness. Ulcers or other gastrointestinal problems may cause vomiting of blood, bloody diarrhea or urine. It is not as important for you to know the specific organ involved as it is to recognize that the patient is in shock and respond appropriately. Signs and symptoms of internal bleeding. Pain, most common, swelling in the area of bleeding, distension, bleeding into the chest cavity or lung may cause dyspnea, tachycardia, and hypotension, and hemophilia, bright red blood that is coughed up. Hematoma, a mass of blood in the soft tissue beneath the skin. Bruising, a contusion, or echomeresis may not be present initially. Bleeding from any body opening. Bright red bleeding from the mouth or rectum. Hematuria, blood in the urine. Non-menstrual vaginal bleeding. Hematuremesis is vomited blood, bright red or dark red. Coffee grounds appearance. Melania, black and foul-smelling tarry stool with digested blood. Pain, tenderness, bruising, guarding, or swelling, possible closed fracture, broken ribs, bruises over the lower part of the chest, or a rigid, distended abdomen indicate possible lacerated spleen or liver. Hypoperfusion, hypovolemic shock. Change in mental status such as anxiety, restlessness, or combativeness, weakness, faintness or dizziness on standing, changes in skin color or pallor, pale skin. Later signs of hypoperfusion suggest internal bleeding include tachycardia, weakness, fainting or dizziness at rest, thirst, nausea and vomiting, cold, moist, clammy skin, shallow, rapid breathing. dull eyes, slightly dilated pupils that are slow to respond to light, capillary refill of more than 2 seconds in infants and children, weak, rapid, thready pulse, decreasing blood pressure, altered level of consciousness. Patients with these signs and symptoms require prompt transport. Scene size up. Scene safety. Be alert to potential hazards. At vehicle crashes, ensure the absence of leaking fuel and energized electrical lines. In violent incidents, make sure police are on scene. Follow standard precautions. Mechanism of injury, nature of illness. Determine the MUI or NOI. Consider the need for spinal mobilization and additional resources. Consider environmental factors such as the weather. Primary assessment. Do not be distracted from identifying life threats. Form a general impression. Note important indicators that alert you to the seriousness of the patient's condition. Be aware of obvious signs of injury and distress, such as a facial grimace. Determine the patient's gender and age. Perform a rapid exam. Look for life threats and treat them as you find them. If the patient has obvious life-threatening external bleeding, address it first. Assess skin color. Determine the level of consciousness using the AVPU scale. Airway and breathing. Consider the need for spinal mobilization. Ensure a patent airway. Look for adequate breathing. Check for breath sounds. Provide high-flow oxygen or assist ventilations with a bag valve mask or non-rebreather mask. Insert an oral pharyngeal airway to secure the airway if the patient is unconscious. Circulation. Assess pulse rate and quality. Determine skin condition, color, and temperature. Check capillary refill time. Control external bleeding. Treat for shock. Apply oxygen, improve circulation, and maintain a normal body temperature. Transport decision. Assessment of ABCs and life threats will determine the transport priority. Patients who may have significant bleeding will quickly become unstable. Signs that imply the need for rapid transport include tachycardia, tachypnea, low blood pressure, weak pulse, and clammy skin. History taking. Investigate the chief complaint. Look for signs or symptoms of other injuries due to the MAOI or NOI. Note obvious signs of internal bleeding. Look more carefully in this step. In a responsive trauma patient who has an isolated injury with a limited MOI, consider a focused assessment before assessing vital signs and obtaining a history. Assess the entire patient, looking for the source of the problem, pre-existing illness, or other issues. Sample history. Ask the patient about blood thinning medications. If the patient is unresponsive, obtain history information from medical alert tags or bystanders. Look for signs and symptoms of shock. Determine how much blood has been lost. Secondary assessment. Record vital signs. Complete a focused assessment of pain. Attach appropriate monitoring devices. With a critically injured patient or short transport time, there may not be time to conduct a secondary assessment. Assess all areas of decap BTLS. Head. Look for uncontrolled bleeding from large scalp lacerations. Abdomen. Feel all 4 quadrants for tenderness or rigidity. Extremities. Record pulse, motor, and sensory function. Vital signs. Assess baseline vital signs to observe the changes that may occur during treatment. A systolic blood pressure of less than 100 millimeters mercury with a weak, rapid pulse should suggest the presence of hypoperfusion. Cool, moist skin that is pale or gray is an important sign. In geriatric patients and patients who take certain blood pressure medications, the pulse rate may not increase with early shock. Try to determine the patient's baseline blood pressure. Obtain a medical history and list of medications. Reassessment. Reassess the patient frequently, especially in the areas that show abnormal findings during the primary assessment. Signs and symptoms of internal bleeding are often slow to present. Children will compensate well for blood loss and then crash quickly. Reassess an unstable patient every 5 minutes and a stable patient every 15 minutes. Interventions. Provide high-flow oxygen, control external bleeding, provide treatment for shock if applicable, and transport rapidly. If internal bleeding is suspected, apply high-flow oxygen via a non-rebreather mask and provide rapid transport. Do not delay transport of a patient to complete an assessment. Communication and documentation. Recognize, estimate, and report the amount of blood loss and how rapidly or over what period of time it occurred. Communicate all relevant information to the staff at the receiving hospital. Communicate your findings and any interventions used. Document all injuries, the care provided, and the patient's response. Emergency medical care for external bleeding. Follow standard precautions. Wear gloves, eye protection, and possibly a mask or gown. Make sure that the patient has an open airway and is breathing adequately. Provide high-flow oxygen. If obvious life-threatening bleeding is present, control it as quickly as possible. Several methods are available to control external bleeding: direct even pressure, pressure dressings, and/or splints, tourniquets. Direct pressure. Most effective way to control external bleeding. Pressure stops the flow of blood and permits normal coagulation to occur. Apply pressure with your gloved fingertip or hand over the top of a sterile dressing. For an object protruding from the room, apply bulky dressings to stabilize the object in place. Apply pressure as best you can. Never remove an impaled object from the wound unless it is in the cheek and blocking the patient's airway. Hold uninterrupted pressure for at least 5 minutes. Follow steps in Skill Drill 25-1 to control external bleeding with direct pressure. Pressure dressing. Firmly wrap a sterile self-adhering roller bandage around the entire wound. Use a 4x4 sterile gauze pads for small wounds and sterile universal dressings for larger wounds. Cover the entire dressing above and below the wound. Stretch the bandage tight enough to control the bleeding. You should still be able to palpate a distal pulse on the injured extremity after applying the dressing. Do not remove a dressing until a physician has evaluated the patient. Apply additional manual pressure through the dressing. If necessary, add more dressings over the first. Bleeding will always stop when pressure of the dressing exceeds arterial pressure. Hemostatic agents. Any chemical compound that slows or stops bleeding by assisting with clot formation. 2 forms. Granular powder can be inserted into small wounds to create a tight seal. Gauze impregnated with a clay substance can be used together with direct pressure when direct pressure alone is insufficient. The use of hemostatic agents in EMS remains largely experimental. Be aware of and follow your local protocols. Tourniquet. The tourniquet is useful if a patient has sustained bleeding from an extremity injury. Several different types of commercial tourniquets are available. Follow the manufacturer's instructions. Follow the steps in Skill Drill 25-2 to apply a commercial tourniquet. If a commercially tourniquet is unavailable, you can create a tourniquet using a triangular bandage and a stick or rod. Fold the triangular bandage until it's 4 inches wide and at least 6 or 8 layers thick. Wrap the bandage around the extremity twice. Place the bandage high and tight, proximal to the injury. Tie 1 knot in the bandage. Place the stick or rod on top of the knot and tie the ends of the bandage over the stick in a square knot. Use the stick or rod as a handle and twist it to tighten the tourniquet until the bleeding has stopped. Secure the stick in place and make the wrappings neat and smooth. As a last resort, you can use a blood pressure cuff as a tourniquet. Whenever you apply a tourniquet, make sure you observe the following precautions. Do not apply a tourniquet directly over any joint. Always place the tourniquet proximal to the injury. Make sure the tourniquet is tightened securely. Never use wire, rope, a belt, or any other narrow material because it could cut into the skin. Place padding under the tourniquet if possible to protect the tissue and help with arterial compression. Never cover a tourniquet with a bandage. Do not loosen the tourniquet after you have applied it. Mark the exact time the tourniquet was applied and be sure to communicate the time and site of application and the rationale of application clearly and specifically to hospital personnel. Splints. Air splints, also known as soft splints or pressure splints, can control internal or external bleeding associated with severe extremity injuries. Immobilized fractures. Act like a pressure band dressing applied to an entire extremity rather than a small local area. Used only approved clean and disposable valve stems when orally inflating air splints. Rigid splints will help immobilize fractures, reduce pain, prevent further damage to soft tissue injuries. Once the splint is applied, monitor pulse and motor and sensory function in the distal extremity. Bleeding from the nose, ears, and mouth. Bleeding around the face presents a risk for airway obstruction or aspiration. Several conditions can result in bleeding from nose, ears, and/or mouth, including the following: skull fractures, facial injuries, including those caused by a direct blow to the nose, sinusitis, infections, use and abuse of nose drops, dried or cracked nasal mucosa, or abnormalities, high blood pressure, coagulation disorders, distal trauma. Epistaxis, nosebleed. Common emergency. Occasionally can cause enough blood loss to lead to shock. The blood you see may be only a small part of the total blood loss. Much of the blood may pass down the throat into the stomach as the patient swallows. A patient who swallows a large amount of blood may become nauseated and start vomiting. May be confused with internal bleeding. Most non-traumatic nosebleeds occur from sites in the septum, the tissue dividing the nostrils. You can usually handle this type of bleeding by pinching the nostrils together. Follow the steps of skill drill 23-3 to control epistaxis. Bleeding from the nose or ears following a head injury may indicate a skull fracture. May be difficult to control. Do not attempt to stop blood flow. Applying excessive pressure to the injury may force blood leaking through the ear or nose to collect within the head. This could increase the pressure on the brain and possibly cause permanent damage. If you suspect a skull fracture, loosely cover the bleeding site with sterile gauze pad to collect the blood and help keep contaminants away from the site. Apply light compression by wrapping the dressing loosely around the head. A target or halo-shaped stain may occur on the dressing if blood or drainage contains cerebrospinal fluid. Emergency medical care for internal bleeding. Controlling internal bleeding or bleeding from major organs usually requires surgery and other hospital procedures. Keep the patient calm, reassured, and as still and quiet as possible. Provide high-flow oxygen. Maintain body temperature. Splint the injured extremity, usually with an air splint. Never use a tourniquet to control the bleeding from closed internal and/or soft tissue injuries. Follow the steps in skill drill 25-4 to care for patients with internal bleeding. Okay, class, let's go over some review questions. Review question 1. Which of the following is not a component of the cardiovascular system? A. Heart. B. Lungs. C. Venules. D. Plasma. The correct answer is B. Components of the cardiovascular system include heart, blood vessels, arteries, arterioles, capillaries, venules, and veins, and blood, plasma, and blood cells. The lungs are a component of the respiratory system. A, heart. This is part of the cardiovascular system. B is the correct answer. Venules and plasma are both part of the cardiovascular system. Review question 2. Perfusion is the most accurately defined as the removal of adequate amounts of carbon dioxide during exhalation. B, the intake of adequate amounts of oxygen during the inhalation phase. C, circulation of blood within an organ with significant amount of oxygen. D, the production of carbon dioxide which accumulates at a cellular level. The correct answer is C. Perfusion is the circulation of blood within an organ and tissues with significant amounts of oxygen and other nutrients. Carbon dioxide is the byproduct of normal cellular metabolism. It should be returned to the lungs for removal from the body. It should not accumulate at the cellular level. Answer A, removal of carbon dioxide is part of exhalation and not perfusion. Answer B, this is a function of ventilation and not perfusion. Answer C is the correct answer. Answer D, carbon dioxide is a normal byproduct of cellular metabolism and should not accumulate in the cells. Review question 3. A man involved in a motorcycle crash has multiple abrasions and lacerations. Which of the following injuries has the highest treatment priority? A, widespread abrasions to the back with pinkish ooze. B, 3-inch laceration to the forehead with dark red flowing blood. C, laceration to the forearm with obvious debris in the wound. D, 1-inch laceration to the thigh with spurting bright red blood. The correct answer is D. Bleeding from an artery produces bright red blood that spurts with the pulse. The pressure that causes the blood to spurt also makes this type of bleeding difficult to control. Blood loss from an arterial wound is more severe and thus more life-threatening than from a venous wound. Answer A. Abrasions are painful but not an immediate life threat. Answer B. Venous bleeding is controlled after arterial bleeding is controlled. Answer C. There is no indication that this wound is actively bleeding. D is the correct answer. Review question 4. Which of the following sets of vital signs is least indicative of internal bleeding? A. BP of 40/90, pulse rate of 50 beats per minute, respirations of 8 breaths per minute. B. BP of 100/50, pulse rate 120 beats per minute, and 24 breaths per minute. Answer C. BP of 98/60, pulse rate of 110 beats per minute, and respirations of 28 breaths per minute. D. BP of 102/48, pulse rate of 100, respirations 22. The correct answer is A. Internal hemorrhage typically reveals vital signs that are consistent with shock, hypotension, tachycardia, and tachypnea. Hypertension, bradycardia, and bradypnea, choice A, is consistent with closed head injury, not internal bleeding. A is the correct answer. B, this is indicative of a progression to decompensated shock. Answer C, this is indicated of progression to decompensated shock, and so is D. Review question 5. When caring for a patient with internal bleeding, the EMT must first A, ensure a patent airway, B, obtain baseline vital signs, C, control any external bleeding, D, take appropriate standard precautions. The correct answer is D. All of the interventions in this question must be performed. However, before providing patient care, whether the patient is bleeding or not, the EMT must first ensure that he or she has taken appropriate standard precautions. Answer A, this would be the first step after standard precautions. B, this would be the third step after standard precautions, airway and bleeding control. This would be the second step after standard precautions in airway. Review question 6. The quickest and most effective way to control external bleeding from an extremity is A. A pressure bandage, B. Direct pressure and elevation, C. A splint, or D. A tourniquet. The correct answer is B. Direct pressure is the quickest, most effective way to control external bleeding from an extremity. This will effectively control external bleeding in most cases. A. This is done after direct pressure has not controlled the bleeding. B is the correct answer. C. Most cases of external bleeding can be controlled by direct pressure and elevation and do not require a splint. D. This is the last method of controlling external bleeding. Review question 7. When applying a tourniquet to an amputated arm, the EMT should A. Use the narrowest bandage possible, B. Avoid applying the tourniquet over a joint, C. Cover the tourniquet with a sterile bandage, D. Use rope to ensure that the tourniquet is tight. The correct answer is B. If you must apply a tourniquet, never apply it directly over a joint. You should use the widest bandage possible and make sure it is secured tightly. Never use wire, rope, or a belt or any other narrow material, as it could cut the skin. The tourniquet should never be covered with a bandage. Leave it open and in full view. A. You should use the widest bandage possible. B is the correct answer. C. You should never cover a tourniquet with a bandage. It needs to be left in plain view. D. Never use wire, rope, belt, or any other narrow material as it could cut and damage the extremity. Review question 8. A 70-year-old man is experiencing a severe nosebleed. When you arrive, you find him leaning over a basin which contains an impressive amount of blood. He has a history of coronary artery disease, diabetes, and migraine headaches. His BP is 180/100 and his heart rate is 100 beats per minute. Which of the following is the most likely contributing factor to his nosebleed? A. His blood pressure, B. His history of diabetes, C. The fact that he is elderly, or D. His heart rate of 100 beats per minute. The correct answer is A. Several conditions can cause a nosebleed, including skull fracture, facial injuries, sinusitis, high blood pressure, coagulation disorders, and a digital trauma. A BP of 180/100 indicates a significant amount of pressure on the arteries, which is no doubt the main contributing factor to the patient's nosebleed. A is the correct answer. Diabetes can be cause of hypertension and vascular problems, but typically is not a condition that will cause a nosebleed. C. Elderly patients are prone to hypertension, which can cause nosebleeds, but age is not a factor. D. His heart rate may be a result of his age or a compensatory mechanism dealing with blood loss. Review question 9. When caring for a patient with severe epistaxis, the most effective way to prevent aspiration of blood is to A. Insert a nasal oral pharyngeal airway and lean the patient back. Tilt the patient's head forward while he or she is leaning forward. Place the patient supine with his or her head in the flex position. Tilt the patient's head forward while he or she is leaning backward. The correct answer is B. Leaning forward with the head tilted forward will stop blood from trickling down the throat. This decreases the risk that the patient will swallow the blood, which may cause vomiting or aspirating the blood into the lungs. Question A. Never insert a nasopharyngeal airway into active bleeding nares. B is the correct answer. Lying a patient supine with a nosebleed will cause blood to be swallowed and may cause vomiting. Answer D. Tilt the patient's head forward, but the patient's body must also lean forward. Review question 10. Controlling internal bleeding requires A. Applying a tourniquet, B. Surgery in the hospital, C. Positioning the patient in the sitting position. D. Providing slow and considerate transport. The correct answer is B. Controlling internal bleeding usually requires surgery that must be done in the hospital. To care for the patient in the field, administer high-flow oxygen and assist ventilations if needed. Control all obvious signs of external bleeding. Monitor and record the vital signs every 5 minutes. Place the non-trauma patient in the shock position. Keep the patient warm and provide immediate transport. Answer A. Never use a tourniquet to control bleeding from closed internal soft tissue injuries. B is the correct answer. C. You should place the patient in the supine position. D. You should provide immediate transport. This concludes the lecture on Chapter 25, Bleeding. Thank you for listening. If you have any issues or questions, please contact your instructor, and I will see you in the next chapter.